Good afternoon. Can you hear us? Can you hear us?
Yeah, we can hear you.
Yeah, and you can see us as well. Good afternoon.
Good afternoon.
Thanks to India Live for the invitation. Let me introduce my team. So I do have with my senior resident, Dr. Prasant,
Good afternoon.
Dr. Praveg, and nursing team include Dr. Ms. Parampreet and technical staff, Sucha Singh is there with me. So let me present the presentation of this particular case. Dr. Prasad, please. PowerPoint presentation.
This 56-year-old chronic smoker male presented with acute inferior MI on 10th February 2016. He was thrombolized with streptokinase in emergency room. ECG showed ST elevation in 2-3 AVF with complete heart block. After thrombolysis, it was successful thrombolysis. There was resolution of ST segment and patient was pain-free. This was the post-thrombolysis echocardiography showing ejection fraction of 60% with no regional wall motion abnormality with no mitral regurgitation. Coronary angiography was done on 11 February, the next day, which revealed normal left coronary artery, and there was anomalous origin of right coronary artery from left coronary sinus. As you can see, there is anomalous RCA from left coronary sinus. LV angio revealed ejection fraction of 60% with no regional wall motion abnormality. A CT angio was done, which also confirmed the origin of right coronary artery from left coronary sinus with an interarterial course. And it also showed proximal significant stenosis.
So this is the case to be done. My question to the chairperson and moderator, which route should I take, radial or femoral? And which guide catheter should be taken for this particular case? Any comment?
Yeah, Rajesh, it's Ajit here. This left cusp right coronary,
Yes.
I normally use a JL3. We could use JL 3.5 also,
Okay.
or an AL, one of these three. It depends on the aortic root size, but these are the three things I would use.
Hi, Vijay. Vijay, this is
Okay.
Vijay. We have Dr. Amal Banerjee. We have Amal Banerjee, Shantanu Goa, Dr. Pelajani, Kirti Panamia here,
Sir.
Ajit, Suresh, and Dr. Vijay Bang. So you have a huge amount of people and also a host of moderators. So tell us what you have in mind, and then we can put in our comments.
See, I have gone through the article from Dr. Ajit, who is also a chairperson just now. Any comment from his side? Next slide, please. Next PowerPoint slide, please. Next PowerPoint slide, please.
Vijay, while you're there, did you
Okay,
have
so
any
Dr. Ajit Mullasri's paper on the Indian Heart Journal has this is about, say, type of anomalous RCA origin from the left coronary sinus, which can be A, B, or C type, depending on the origin of right coronary artery. And here we do have now type C type of anomalous RCA, which is arising from the mid part of the left coronary sinus. Next slide, please. And this is the experience of mine about the anomalous RCA. By now, I had done around 16 cases, and most of the time I use AL1 guide. So here we are with the anomalous RCA from left coronary sinus, and I have approached the transfemoral route and has taken the AL1 guide. And I was able to hook the right coronary artery by the AL1 and could able to cross the wire across the proximal lesion. And this is the cine-angiogram. So there is problem of selective cannulation, but then of course I am able to cannulate it partially and could pass the wire across it. Let me go ahead with the balloon across the RCA, and then with the balloon inflation, I can very well selectively cannulate the right coronary artery.
Vijay, this is Kirti here. No, the problem with most of the guides
Yes,
in this
that is
kind of
getting-
anatomy is they don't engage the artery very well, and you end up injecting a lot of contrast in the aorta.
that's right, that's right,
So
that's right.
So what I've done is I've taken 7 guides usually, and then once the wire and the balloon are there, anchor the balloon and see if a mother and child, a child catheter can go selectively into the artery. That way you save contrast and you make your life much easier. I don't know if that is an approach that you would consider at any stage. Not.
No, I'm going to anchor the balloon across the RCA and then going to selectively engage the AL1 instead of taking the mother and child catheter. So, can you inflate it?
Vijay, you asked
Dan?
a question whether in a case like this is Dr. Palajani here, whether one should use the femoral or the radial
Yes, yes, sir.
route. I would prefer in such a case a femoral route. The reason is many times you need a little longer or prolonged maneuvering, and you need maneuvering and easy maneuvering, which is much
Right, right.
easier with the femoral route than with the radial route. So I would feel that doing so would be better in a case like this, going through the femoral route. That would be my preferred route. You have gone what, femoral or?
Say, out of my 16 case, I have gone femoral, and it's a 6F AL1 guide, which I have used. Among the 16 cases which I had done, around three patients had a transradial approach, because it was the reason for transradial was that I have gone for the diagnostic angiogram via transradial, and therefore I could do it. But here, of course, I have gone transfemoral and then could able to dilate the lesion. And now, after anchoring the balloon, I could certain extent have a selective cannulation of right coronary artery. The origin of RCA, ostium of the RCA seems to be okay. There is a concern about. Yes, please.
Also, you have preferred to take the
Origin of RCA, which is.
In a situation like this, I have preferred to take the Judkins left, because that I can loop it like a U, and many times I've been able to get quite deep into the right coronary artery sinus. Because here, you're trying to put it like this, maybe sometimes you get into the left coronary artery, may injure it. So I would feel that my first preferred choice would be to take a left Judkins 3.5. But of course, the choice is yours.
That's right. Type A and B is the one where there is a risk of left coronary ostial dissection. But here, this type of RCA, which is type C, I think I am comfortable enough to use the AL1 guide. Let me dilate the distal lesion as well.
What is your option regarding the guide cath as suggested by Palajani ji? Whether you go for the Judkins or right with 3.5, right Judkins.
Uh,
I think I would go along with
out
what Dr. Kirti Puname has suggested.
right
A
Judkins, I
guideliner
have
would be a
not
very
tried.
safe and very stable option.
Ajit? What
See,
is
I
your
have
comment?
not used the JR guide. I mean, it's either left, either,
Yeah, well, we published this paper in Indian Heart Journal a year ago. And
so this is what after the
yeah, Rajesh, there was a
Yes,
question
that's
whether what guide I would use. So I agree with you. If the left is coming, if the right is coming very close to the left coronary, like a A or B, which you showed, I think a JL3
Left.
or 3.5 is great. But if it's a C, which is coming more anteriorly and above like this, I think the AL1 is a guiding
Right.
which is good. The modified AL1 is possibly what is suggested in the books, but I think AL1 is good enough.
That's why I use the AL1 because this is type C, and then I think I'm comfortable to do the selective angiogram as well of right coronary with this AL1.
Yeah. Rajesh, this is Dr. Vijay Bang. Can you hear me?
Please.
Yeah. What I suggest is
Yes,
if you,
yes, I can hear you.
If you rotate anti-clockwise or clockwise, you will be able to engage the guiding selectively into the ostium of the right coronary. The same guiding. I'm talking about amplifier 1 that you
Okay,
use.
let me try it. Let me try it. Inflate the balloon, please. 8.
Dr. Mishra
So
here.
here I have
The
anchored the
risk
balloon.
of
Let me push
dissecting the
guiding
ostium of
slightly
coronary would be
more.
high using a AL1 in
Negative.
this situation. And that is why I would really prefer what Dr. Punamaya has suggested, that keep your guide close, use a guide liner, and that is a much softer catheter and much more forgiving.
So,
therefore you may
relatively
escape
better.
with
3.538. So after certain pushing and certain rotation, I am now more selectively been cannulating the right coronary. The wire, please.
The cath lab, since they are
And
waiting,
here we are with the stand. It's a
just we'll come back.
here we are there.
We'll
with
come
the
back. We
stand,
are going to another cath lab. They are
3.538.
waiting.
Okay, fine, fine. Go back. Back, back. Okay, next. Next. Back, back. क्या कर रहे? Okay, so we could place 3.538 alpine stent from Abbott vascular distally in the distal RCA. This alpine stent claim to have a better trackability and pushability compared to the older generation Abbott stent. Next slide, please. This I had deployed at 15 atmosphere.
The audiovisual needs to switch over. We are still seeing the Kochi lab here.
Next, please.
Yeah. Anyone from audiovisual here?
Get back, ja. Back.
Yeah, okay.
Can you hear us?
Now we can. Go ahead.
You give me this was how much? Show me the last shoot. Show me the last shoot. This is how much? 15.
So we'll go with the 2.518 or
20.
20. 2.520.
20.
We're cross-talking between Kochi and Chandigarh. I don't know what has happened.
3.528 in the proximal.
Rajesh, is that your second stent?
Can you clearly listen us now?
Yeah, yeah.
Yeah, so this is the second stent, 3.528 across the proximal RCA. Next. This again when deployed at 15 atmosphere. Next. And then we have dilated with 3.5 non-compliant balloon at 20 atmosphere across the stented segment. Next. 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 Distally, there was some under-dilatation where I again inflated the 3.5 millimeter balloon at 24 atmosphere. Next. So this is the result across the RCA. Next. And we have done the IVUS, which has shown the well-opposed stent across the RCA. Can you show the IVUS? So here's the IVUS. It's not coming. Yeah, it's coming. So IVUS do show a well-opposed stent tracts. Distally, there was a fibrotic lesion which we already dilated with the 3.5 millimeter balloon at 24 atmosphere. Next in. Next in. Result of the anomalous RCA. Any comment?
Proximal stent needs to be post-dilated by NC balloon. See, there is a disparity in the lumen size of the distal stent.
I
to
had
proximal.
dilated it with three.
I think it need to be post-dilated by bigger balloon, I think.
It's been dilated at 3 with the 3.5. IVUS do so well opposed stent stretch proximally as well. Do you feel I should dilate it with 4 millimeter?
No, you have an IVUS. Why don't you look at that IVUS? You did an IVUS, didn't you?
IVUS we have seen.
So
You couldn't show the IVUS.
yeah.
Again replay the IVUS proximally. IVUS has shown a well opposed stent stretch proximally as well as distally. This is the IVUS. Can you see the IVUS screen? Can you see the IVUS over there?
We can, but I wish it was a bigger screen.
Yeah, that's
yes,
what.
that's better. So I think the point over here is as a final land. I mean, where do you end using IVUS as a guidance? I mean, if you put in a 3.5 millimeter stent, then you need to have a 9.6 millimeter square cross-sectional area of the stent. So what is important is in that 3.5 millimeter stent area, if angiographically it looks small, then do a cross-sectional area. And if it is small, then you go up gradually with quarter-sized balloons and try to get it optimally opened, and that would be a good IVUS result. But the question is, how do you define?
I think this end result with the IVUS seems to be satisfactory. Any further comment?
I think so far it's been well expanded and well opposed, but just the proximal, very proximal part of that. So unless we have fluoroscopy, we won't know where we are in that area. But
Can you show the end part of the stent on IVUS? We can very well demonstrate the proximal part of the stent. Show the proximal part of the stent in the IVUS.
so whoever's on the IVUS machine, can he go to the proximal edge of the stent and then move inside the stent?
So this is what?
Yeah. That looks like the
That's
distal
right.
end.
Here we are at the proximal end of the stent. Here we are at the proximal end.
This,
No, it is proximal, is it?
no, this is, can you have the
is
longitudinal
proximal?
view and then you can
This is
do-
proximal end.
Can you have the longitudinal view down so that you
Show
can
the
know-
longitudinal view.
Okay, now go ahead. Now go proximally would be
Yeah, here
this
is the
end.
longitudinal view.
Yeah, so come to this end.
Go proximal.
Yeah. Go into the stent. You're coming out of the stent. This is outside the stent. Now go to the right. Yeah.
Yeah, here, here.
Yes. Yes. So
Go to right,
now look at
right,
the cross-sectional area here. What is the cross-sectional area?
Here
Just
is the stent.
do a trace. Stop and do a trace.
Cross-sectional area. Trace.
Trace.
Cross-sectional area.
So the red needs to come out here. Now, if you look at this area is 9 point something. It's 10. I think 10 is a very good area, and I think you should not try and overexpand this
How much?
10.
How much it is?
It looks like well expanded. What do you say, Ajit? This is a lot of.
So do you feel it's okay?
Yeah, I think so.
Well, I think just put those points together once more so that, you know, we're okay with the whole measurement. From here, well, it's, yeah. Anyway, it looks close to 10, Rajesh, so I think it's reasonable for a 3.0 vessel, 3.5 vessel. Yeah, so I think right now there's no IVUS guidance needed to upgrade your balloon or your pressure right now, IVUS base. So on the basis of the IVUS, you're comfortable to leave this alone. Angiographically agreed, it looks
Okay,
a little
fine,
more,
fine. For
you
close
could
device.
possibly look at work, but IVUS is better for this decision.
Should I
and
stop
think
over
I would-
here? I think it's a satisfactory result. Final result. Final result.
Yep, Rajesh, thank you very much for
So
a
this is what
nice
we have
demonstration.
achieved. Final result. Let me come out. Thank you. Thank you.
Well done, Rajesh.
Thanks
Go to the other
everybody.
lab. Can we go to the other
Thanks
lab
India
now?
Live. Bye. Bye.
Kochi.